Now, we all know that fever, dry cough, and flu-like symptoms are the common symptoms, but the severe symptoms which we have to be always careful about, or we have to be on the lookout for dyspnea, chest pain, hemoptysis, and respiratory insufficiency. Now, this is one slide which I thought I would share with you. Why are we scared? If you look at the symptoms of flu and COVID, find that everything is almost similar. But the complications in flu are less likely because of the we've been facing influenza virus for a very long time, and there is immunity building over a period of time. Uh, However, with COVID-19, there is severe respiratory complications which are more likely because we do not have the requisite immunity. Another thing, why are we scared? Because for flu, there is a flu shot and there is some treatment of doubtful efficacy in the form of oseltamivir. But for COVID-19, although there are very many drugs in pipeline, but we don't have anything more than self isolation and just preventive strategies which are working. This we had discussed earlier that Ministry of Health divides the COVID positive patients or suspects into mild, moderate, and severe. If you have influenza like illness, fever with upper respiratory tract symptoms like cough, coryza, then you have a mild illness. If you have pneumonia with a respiratory rate of more than 30 and an oxygen saturation of less than 90%, or you have hypotension and ARDS, then it is severe. Anything in between these two is moderate disease. Uh, it's important to emphasize again uh, who is a close contact. Now, whenever you have a positive COVID patient, any healthcare worker who is providing direct care to COVID patient is a close contact. Anyone who's working with these healthcare workers who are providing care to positive patient is also a close contact. And anyone who's visiting or staying in the same close environment of a positive COVID patient is a close contact. If you've been working together, you become a close contact. If you've been traveling together with a COVID patient in any kind of conveyance, you are a close contact. If you're living in the same household, or if there is an epidemiological link that someone you met for a significant period of time for a 14-day period without taking any personal precaution or maintaining a safe distance from them, then you become a close contact. Now, this again is very clear. When you have a suspect case, you should not keep them together with a positive case. Healthcare center for COVID suspects and positive should be a standalone building, and if it is not possible, then a block needs to be isolated. Where you keep the positive patient, it has to be a dedicated ward, ideally having separate rooms and a dedicated beds for sick patients like we have in PGI, and all the staff, that is doctors, nurses, but more important than even doctors, nurses, is the people who are taking care of the waste disposal and also the hospital attendants. They need to be trained. Uh, an uncomplicated illness is patients who have only fever, cough, sore throat, nasal congestion, headache, muscle pain, or malaise. But an elderly or an immunosuppressed patient may present with atypical symptom. They just may present with shortness of breath. Some of them have known to present with altered sensorium, only hypoxia, only headache, severe myalgias. So in elderly and immunosuppressed patients, you should be always more careful. Uh, this is a chest X-ray, which, if you look carefully, has some infiltrates on the right lower zone. Patients who have cough with difficulty in breathing and there are no signs of severe pneumonia, you will call them mild pneumonia, and they are classified as moderately sick COVID patients. Severe pneumonia, any adult or an adolescent who presents with with respiratory infection with a rate of more than 30, severe respiratory distress, and oxygen saturation of less than 90%. Although I have shown the X-ray and the CT scan here, but let me caution you here that a CT scan is not a must for making a diagnosis of coronavirus infection. You can isolate the virus from nasopharyngeal or the throat swab, and a chest x-ray can give you, along with clinical clues in the form of oxygen saturation, give you enough clues to make a diagnosis of severe pneumonia, and you do not need to do a CT scan in every patient. In children, it is a little kind of different. You may have central cyanosis or a saturation of less than 90%, severe grunting or chest indrawing, inability to breastfeed, drink, there is lethargy, coma, or convulsion, and in case the respiratory rate, which has been kind of depicted here, if it is very fast respiration and all the other signs, you think that these patients would have severe pneumonia. ARDS is new onset. ARDS classically defined new onset or worsening respiratory symptom within a week of known clinical insult, and you can have an clinical parameter of oxygen saturation, or you can also use FiO2, SpO2 with the oxygen saturation and FiO2 ratio, which you can use for diagnosing an acute respiratory distress syndrome. CT scan should again only be done if it is needed, not a must. These are various kinds of X-ray pictures which you can see, starting from the first one on the left upper, on your right upper corner, which is a mild disease, possibly mild infiltrates in left lower zone and some infiltrates on the right lower zone, and then you have the progressively increasing shadows in the chest, which can depict severity of the illness. Some CT scan features which show diffuse ground glassing, most of the lobes, so that can also be kind of helpful in making a diagnosis of severe COVID pneumonia, or can help you in diagnosing ARDS. Now, this is what I was telling you. If you have a clinical picture, you have an X-ray, and if you just measure the PaO2 FiO2 ratio, if it is less than 300 millimeters Hg, you will classify it as mild ARDS. If it is less than 200, it is moderate, and if it is less than 100 with PEEP of more than 5, or in a non-ventilated patient, you will classify as severe ARDS. Now, a question which is commonly asked is that in places where you do not have an facility to get an ABG, how do you make the diagnosis of ARDS? There you can use an SpO2, that is saturation, oxygen saturation by a finger probe, and FiO2 ratio of less than 315. That will suggest an ARDS in non-ventilated patients.